We've got a special guest today. My name's Dr. Ronald Wei. I'm one of the founders of this YouTube channel, and here with me is Dr. Leon Chen, one of my good friends and also a consultant neurologist, FRACP. Leon, say hi. Tell us a little bit about yourself and what you're doing right now.
Hi, Aaron. Thanks for having me on the show. I am a general neurologist, fully qualified FRACP like yourself, and I'm working up here in Cairns, splitting my time up in sunny Cairns and also in down in the Central Coast, where you are at the moment.
We're good friends. We trained in the Illawarra network, and those were good times. But today's talk, I want to keep it sort of casual, but just a brief, sharing of our perspectives about the clinical examination period, and maybe we can throw in some nuggets for our viewers. The clinical examination was a tough time in both of our lives. Leon, so we had both, you had passed the written, I had passed the written, and we sort of met up in the Illawarra network. I think we'll just maybe talk about the clinical examination. What are your thoughts about it? What are your comments about it? And then we'll talk a bit about how we went preparing for it. So do you want to give your take on life during the clinical examination and how you approached it and what you think about the exam?
Yeah, the clinical examination is always a stressful period for, I guess, most candidates. So, quite demanding. You have a short period of time to master quite a broad set of skills, though. But I think the main thing is just, again, finding a bit of a framework and trying to break it down into sort of smaller chunks, those sort of quick, consistent pieces of work, I think is what I would say, though, in terms of not cramming everything at the last minute and just having practice and sort of trying to set yourself achievable goals in a timeline.
I think for me, I split it into thinking about it in a short case point of view and a long case point of view. And like you said, there's multiple facets of the examination. For me, I felt it was sort of being able to gather information, being able to synthesize information, be able to present information, and then formulating a discussion with the examiners. That's why I kind of subdivided it into sort of the four categories. And obviously, having a good knowledge base is very important, but also a good examination technique I found to be very, very important, as you know. And so obviously you got to collect the information and do all of these other steps in a timely manner. Roughly how many long cases did you do prior to taking the exam?
Personally, I don't quite remember. I know there are people who've set out specific numbers in terms of 50 or 20, but I'd say on average I probably would have done probably a long case a week more or less, or a fortnight, and that would translate to, I guess, about maybe 20 to 30 long cases. But more important than that, I think, is just the variety of what you see in terms of your long cases. And the idea is that it's just meant to prepare you for the different permutations and variations in cases and to help you think on your feet a bit, though, by doing a variety of cases of varying complexities and diagnoses.
Yeah, and I think that's very important, Leon.
So the number of cases, just to answer your question again, and I don't think there's a particular set number of cases. I know people go with certain numbers, you need to do 50 or 40, but in my time, I think on average, it's just being consistent. I don't quite recall my own numbers, but probably I'd say I've completed it somewhere between 20 to 30 cases at least prior to the examinations. And more importantly than that, it's just, I guess, the variety of cases you put yourself through a practice in terms of finding variety in the issues and the diagnoses that the patients present with, because a lot of it's just about thinking on your feet and working through the different permutations at the time, so you've come across it once at least.
Okay. I think I did about 20 to 30 as well. I think that's a ballpark good number. But like you've said, I think it's very important to stress quality over quantity. You can do 50 bad long cases and I don't think you'll get a very good mark. It's about doing it well. Um, and I remember with the long cases, you had cold cases that you could do and then present later. But our clinical director at the time, our I guess um, network director, she was very encouraging of us to do it as a hot case. So once we were familiar with the examination uh, uh, format, she would ask us to make sure that we examined the patient, took the history within the time, and then immediately present to an advanced trainee or a consultant. Did you find yourself doing hot cases, Leon?
Yeah, I think that's right. I did, and it was useful to have that particular type of experience. And it goes back to my point about sort of being able to pivot and think on your feet, especially when you have to synthesize the information just after you've examined and taken history from the patient, though. And
Mm.
sticks with you, in terms of presentation as what you've done well and what you've done not so well, and how you present yourself under a bit more stress, so to speak.
Yeah, yeah. I think presenting in that time really forces you to polish your case. Um, the other thing I thought was important for our viewers to know was that there are sort of only a set number of different long cases that you can have, and they usually follow a theme, and usually it's along the theme of a competing issue. So a classic examination, a classic example of a long case would be a competing issue of uh, immunosuppression versus infection. So that could be from a transplant, for example. And within transplants, you have, I guess, only a set number of transplants that you need to see, I suppose. Renal transplants, liver transplants, heart transplants, lung transplants, and maybe bone marrow transplants. Can you give any examples of other types of long cases?
Yeah, so I guess the patient who's presenting with a transplant as a major issue is rightfully so one of the large category of patients that you might encounter in the long case. There are other issues, I guess, within the realms of these type of patients, or maybe just other patients as well. The themes, for instance, might include things such as falls prevention, they're managing at home, the maintenance of their functional independence, for instance, and perhaps another common one might be sort of the fact that, and many people are on this sort of anticoagulation and what you decide when it comes to the thrombotic versus the hemorrhagic risk of putting someone perhaps on a therapeutic anticoagulant. Now, these issues, I believe, they do open quite a broad area for discussion, and perhaps that's why it's quite, I guess, an exam favorite
Mm.
in cases. So.
Yeah, the bleeding versus anticoagulation case is always a classic as well, as you've mentioned. A metabolic case is often another favorite. So they have diabetes, hypertension, cardiovascular issues. The renal dialysis case or a chronic kidney disease case I found to be quite common as well. So I think, like you said, there are a variety of cases, but there's only a certain number of permutations, and being prepared for them, I guess making sure you see one of every type is very helpful. Would you agree?
Yes, I do agree. And even if you hadn't seen personally sort of a particular type of case, at least having that mindset, say, for instance, if your colleague or your fellow physician trainees have come up with an issue in a patient like that they've seen, I think even just discussing that particular issue with them uh, might be of some benefit, even if you haven't seen a particular issue that's come across in a patient that you've seen before.
Thank you, Leon. So I'm just going to wrap things up here.